Good afternoon. Welcome to today's webinar, A United Approach to Infants with Neonatal Abstinence Syndrome, NAS, provided through a collaboration between the Pennsylvania Medical Home Initiative, a program of the PA chapter of the American Academy of Pediatrics, and funded by the Pennsylvania Department of Health. This webinar, led by Dr. Kimberly Costello, aims to understand the prevalence of neonatal abstinence syndrome in Pennsylvania, to understand the identification, screening, and treatment of infants with NAS in the hospital, and also to learn how to identify infants after the initial hospital period and how to identify resources available, and to understand what the Pennsylvania Perinatal Quality Collaborative is doing to help keep mothers and infants together in the face of the opioid crisis. I am Dr. Renee Turchi, a pediatrician at St. Christopher's Hospital for Children and medical director of the Pennsylvania Medical Home Initiative at the PA chapter of the American Academy of Pediatrics. This webinar is being recorded. The recording will be available on both the Pennsylvania Medical Home Initiative website and will be posted on the University of Pittsburgh Internet-Based Studies and Education and Research website. For CME purposes, please be advised that none of the speakers today have any disclosures. Please note that the information presented in this webinar is educational in nature and does not necessarily represent the views or policies of the PA chapter of the American Academy of Pediatrics nor its funders. Now, please allow me to introduce our presenter for today's webinar, Dr. Kimberly Costello. Dr. Costello is the Director of Neonatology at St. Luke's University Health Network in Bethlehem, PA. She is the Director of 2 NICUs within the system and soon to be 3. She's the Executive Director of Strategic Relationships for On-Site Neonatal Partners, Incorporated, overseeing physician and hospital relationships, provider wellness, and patient satisfaction. She serves as a clinical leader of recruiting, ensuring on-site hires, and retains high-quality physicians and advanced practice providers who are aligned with the organization's mission, values, and vision. Dr. Costello is Assistant Professor at Temple University Medical School at St. Luke's and was also named the March of Dimes Physician of the Year in 2015. She's presented at the Vermont-Oxford Network Conference for the Goldilocks Project, Improving Admission Temperatures in Very Low Birth Rate in Babies, and is the lead of Micropreemie Collaborative for the network's babies less than 1,500 grams. Her team won the Healthcare Association of Pennsylvania Award in Quality for the pneumothorax project, which focused on reducing pneumothorax rates at St. Luke's in all NICU babies. She was instrumental in expanding the use of donor breast milk at St. Luke's and is heavily involved with the AAP through the Pennsylvania Preemie Network, of which she was on the executive board, who then partnered with the Jewish Healthcare Foundation to form the PA Perinatal Quality Collaborative. This quality collaborative is working with the state and hospitals throughout PA to standardize the care for mothers with opioid use disorder and infants exposed to and affected by maternal opioid use. Dr. Costello is board certified in pediatrics and neonatal perinatal medicine. She graduated with a Bachelor's of Science from University of California, Irvine, and completed medical school at the Philadelphia College of Osteopathic Medicine. She completed both her pediatric residency and neonatal perinatal medicine fellowship at Penn State Hershey College of Medicine. She completed the Certified Physician Executive Certification through the American Association for Physician Leadership. We are delighted to have Dr. Costello present on this timely topic and an important topic for all of us in primary care. At that time, we would like to begin our presentation. And Dr. Costello, thank you for being here today.
Great. Thank you so much for everybody joining us and leading in this discussion about neonatal abstinence syndrome. Please post any of your questions, and we will answer those at the end of the discussion. Okay. So Dr. Turchi did explain the objectives that you can see here. So really we're going to discuss the prevalence of NAS in Pennsylvania, understand the identification, screening, and treatment of infants with NAS in the hospital, learn how to identify infants after the initial hospital period and how to identify resources available, and really understand what the Pennsylvania Perinatal Quality Collaborative is doing to help keep mothers and infants together in the face of this opioid crisis that we are all experiencing. I do not have any disclosures. I am on the advisory board for the Pennsylvania PQC, but I have no financial relationships that conflict. So neonatal abstinence syndrome. So we really need to start off with the definition. So it's very, very important to know that infants are affected by opioid use disorder. So they are substance-exposed infants, and they are dependent on the opioids that their mothers are using. They are not addicted. Oftentimes you may hear that babies are addicted to opioids. It is not true. We want to make sure that language is very important, and language really needs to be spread amongst our community. So the definition of addiction, just to keep all of us on the same page, is addiction is characterized by the inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with one's behavioral state, interpersonal relationships, and a dysfunctional emotional response. Obviously, babies are not able to conduct any of those functions, which is why they are not considered addicted. So NAS is a drug withdrawal syndrome that most commonly occurs in a newborn baby after in utero exposure to opioids. If left untreated, as we all know, NAS can be life-threatening for the neonate, not just because of the physical state that the baby goes through, but also how the families may react. Remember that families that have opioid use disorder oftentimes, not always, but oftentimes do have a difference in how they have coping skills. And so these babies are at very high risk for shaken baby syndrome. So if there is a baby with NAS that is not identified, this baby might be very difficult to console and might be at risk for shaken baby syndrome by their families. So we do need to make sure that we are educating appropriately across all continuums. NAS increases the risk of respiratory complications at birth, increases low birth weight babies, prematurity, feeding difficulties, and even seizures. Some of the symptoms of NAS, which we will go through in detail, but can include hypertonia, vomiting, tachypnea, fever, decreased sleep, excessive crying, excessive sneezing, skin excoriation, inconsolability, and even seizures if it's not treated. It does typically manifest in the first 1 to 10 days of life, and the American Academy of Pediatrics recommends that all opioid-exposed neonates be observed in the hospital for 4 to 7 days after birth for signs of NAS. Oftentimes, hospitals now in Pennsylvania are using 5 days as the average. However, if those scores are still elevated, we are keeping those babies an extra 1 to 2 days in order to make sure that they do not need to be treated for NAS. That does not happen in all birthing hospitals yet. However, it is happening in more and more hospitals throughout Pennsylvania. So neonatal abstinence syndrome, again, is the exposure to illicit or prescription drugs. It passes via the placenta to the baby, and again, the baby has a dependency to this drug, and then withdrawal symptoms occur shortly after birth. Typically, we see babies withdrawing at about the 24-hour mark and beyond. It's pretty unusual to see it in the first 24 hours of life. However, it certainly can happen, especially with the shorter-acting illicit substances that some moms may be using. So you can see some data from the National Institute of Drug Abuse that shows there's a dramatic increase in maternal opioid use and neonatal abstinence syndrome. So this data was published back in 2015, and you can see from the discharge year that neonatal abstinence syndrome is certainly on the rise. So you had the number per 1,000 admissions back in 2004 was about 7 or so. In 2015, we're up to about 30, and I'll show you some data from Pennsylvania that is even more striking. Every 25 minutes or so, a baby is born suffering from opioid withdrawal. So it's a very common diagnosis that we're having. And one of the things that when you're looking at this data to remember is that this data is often from hospital charting. So if a physician is not charting appropriately, meaning we're not putting the problem list into the computer system, these numbers actually might be on the lower side. So we do just have to remember that we still don't have a great way to report all the issues that we are having. Based on this data, the average length and the average cost of hospital stay are really shocking. So babies with NAS, the average length of stay is around 17 days. And without NAS, it's only about 2. And then the average hospital cost per baby with NAS is around $65,000 or so versus a typical newborn baby of $3,500. So the cost financially as well as the cost to the baby of being in the hospital and separated from their families is really incredible. And of course, as you would expect, NAS is on the rise just as maternal opioid use is on the rise, and so you can see those graphs there. So newborns with NAS do stay on average 5 times longer than their counterpart that does not have NAS. So this data is from Pennsylvania, and you can see the 2016 to 2017 data. The rate of NAS per 1,000 newborn stays is about 15. Compared to year 2000, it was 1.2. So really a tremendous burden on the families as well as the healthcare system. As far as the opioid epidemic is concerned, opioid use has increased across the United States among men and women, most age groups, and all income levels. So this is no longer affecting one state, one area of the state, one socioeconomic group, or anything like that. It is really crossing all barriers across the United States, and something that we all really need to become well educated in. Some of the greatest increases occur in demographic groups with historically low rates of opioid use, such as women, the privately insured, and people with higher incomes. So this is why it's important to screen everyone and not to stereotype. It's very important to have a multidisciplinary approach to this and make sure that just as we were testing all moms for hepatitis B and HIV and chlamydia and all of those things, we need to make sure that we are screening them for opioid use disorder, and we'll go through that in a few slides as well. Opioid use has more than doubled among young adults age 18 to 25 in the past decade, and certainly these are women of childbearing years. When you look at the data from 2015, you can just see the rise in the number of prescriptions, the number of deaths, the number of people with opioid use disorder. The data is just striking, and you can see how much money is being spent on this epidemic as well. So it really is quite incredible. Prescription painkiller abuse in the United States certainly is on the rise as well, and that certainly has been in the news as far as what can we do about this. So it's not just illicit drug use that is the issue. Now it is prescription painkiller abuse. So a big part of the overdose problems resulted from prescription painkillers. So you can see the amount of sales in the prescription drugs, and that is the green line. And then you can also see the number of deaths mirror that selling rate, and then you can also see the treatment. So the rate of prescription painkiller sales, deaths, and substance abuse treatment admissions have been increasing from the year 1999 or so to where we are now. And it all mirrors each other, which is why there is such a push now to make sure that that physicians are prescribing appropriately and that we are not using pain as much as a satisfier as we had in years past. Since 1999, the amount of prescription painkillers prescribed and sold in the U.S. has nearly quadrupled. However, there has not been an overall change in the amount of pain that Americans report. So that is really an important statement to remember. So heroin addiction and overdose deaths are climbing as well. So it's not just the painkillers, of course, it is also illicit drugs. And so heroin use has increased among most demographic groups. So when you look at the graph on the side, on the left-hand side, you can see there has been a 100% change in the female demographic that use heroin, 109% change in the age group 18 to 25, 114% change in non-Hispanic whites. The annual household income, there has been a 77% change in those that make $20,000 to $50,000 a year, and then there's been a 60 to 63% change in those that are either not insured or have private insurance. So again, this is really just crossing all lines that we see. This graph I thought was really, really important because it shows you how the epidemic of drug overdose deaths rippled across America. So back in 1999, you can see that the overdose deaths were really more out in the west and maybe the southwest, and that's sort of where the pockets were, and a little bit in the east. But then as you go year by year, you can see down to 2015, this really has now affected everybody across the United States. And it is the deadliest drug crisis in American history and something we really need to get a hold of. So opioid use disorder is an enormous problem among women. So women currently represent about 30% of the addicted population, and of these, a majority are childbearing age, between 15 to 44 years of age. The maternal drug use and subsequent prenatal drug exposure has reached levels of critical concern in the United States, and it's the highest point in nearly a decade. And you can see that data came from the CDC in 2013, and we certainly are not on a decline yet. Opioid abuse and dependence among pregnant women has really increased as well. So you can see the green line there are the women that are aged 20 to 34, and so that is the highest amount of opioid abuse amongst pregnant women. And then you can see overall, it certainly has been rising as well from 1998 to 2011. So we don't have any end in sight just yet. The one thing that we really need to pay attention to also is smoking. So opioids and smoking is perilous. So the maternal impact is really quite striking as well. Studies have shown that smokers compared to non-smokers are more likely to have chronic opioid therapy for pain, higher doses of opioid for pain control, higher risk of drug dependence, and they exhibit more aberrant drug-taking behaviors. So it's really important for us to still focus on smoking cessation in all groups, but certainly prenatally, and then, of course, if the mom is pregnant, to make sure that they are supported and are able to stop smoking during the pregnancy, since it does have such an impact. The infants exhibiting neonatal abstinence syndrome after in utero exposure to maternal opioid use and smoking have increased NAS symptoms and longer duration of treatment of abstinence symptoms. So if you have a baby who seems to be withdrawing a little more significantly than one would expect for whatever the mom is on, whether she's on methadone or buprenorphine, you might want to think about how much has this mom been smoking tobacco. If she has been, and then there certainly is no treatment for that for the baby, so we'll just have to treat that baby longer, but we do want to make sure that the family understands that this is why the NAS is more significant for this baby. So it's important for us to partner with our OB and MFM colleagues, because all of our treatment in the babies start prenatally and then, of course, in the OB office. So it is standard now for all moms to be screened for opioid use during pregnancy. So this is an ACOG statement, an ACOG committee opinion number 711, and it's really important for all moms to be screened. Now, there is controversy about what does screening mean. Screening does not mean testing. So screening typically is a survey, and there's many different surveys that have been validated. So there's the 4 Ps, which is parents, partner, past, and present. There's the SBIRT, and there are others. But these are typically the surveys that are given in the OB's office. Testing is when somebody is testing the urine or the blood for drugs. That is completely different than screening. So it is recommended that all moms are screened for opioid use during their pregnancy. And then if a mom does come up positive with this screening, it's important to discuss it with them, certainly offer resources, and then if they need to refer them to the maternal medication-assisted treatment, but then also have them have a neonatal consult. So when you partner with your OBs, we are able to identify moms who have babies that will be at risk for NAS. And the more information we can give these families prenatally, the better it is for the family situation, because then they can plan. Oftentimes, families don't realize that the baby will be in the hospital for at least 5 days to observe for neonatal abstinence syndrome. So if they are aware of that prenatally, then if they have other kids, they can certainly plan for child care, because we do want to make sure that moms and dads and babies can stay together during this period of time, because it's very important in order to help calm the baby and hopefully keep the baby from being treated. Once the baby's treated, it's important for them to know that the average length of stay is around 3 to 6 weeks, depending on what type of treatment they have, what type of scoring system is being used, and things like that. But again, that can be quite shocking to a family that doesn't realize that this baby may be in the hospital for an extended period of time. We also want to make sure that the families know that they will be referred to children and youth so that resources can become available. Most people feel that when children and youth become involved, it's to take the baby away. So we need to dispel that at the very beginning and to let them know that, yes, that is one function of children and youth. However, if they're in a treatment plan and everything is going well, it's really to offer resources for them, which can be a lot of resources that they don't even realize that children and youth have. So again, very, very important. And they also need to know that we will be testing the baby. So the baby, depending on the hospital that you work at, will do most likely urine and then either meconium or cord toxicology. And so that's important because we want them to know that this is a standard process. We are here to support them. We are here to help them through this process, but that every baby that's exposed is treated the same way so that they don't feel alienated, because the family, of course, feels alienated. They're going to shut down. They're not going to tell you the things that you may need to know, and we're not going to be able to help them as much as we need to. So a neonatal consult is really, really important so that when they do go into labor, all of those expectations are already known and they can just focus on bonding with the baby. Another thing that we have found prenatally that's important is to make sure they understand, as long as there are no contraindications, which oftentimes there's not, but as long as there's no contraindications, that they are encouraged to breastfeed. A lot of moms that are on methadone or buprenorphine don't realize that they can breastfeed. And so once you tell them about that prenatally, you know, that really helps and really increases that bonding experience that they have as well. And of course, breast milk is best for the baby. So we're able to discuss that before the mom goes into labor. And then, of course, any information that you may have for the NAS parents, you can give that to them so they can start looking into resources before the baby is even born. So the rate of NAS per 1,000 newborn stays, this is 2016 to 2017 for Pennsylvania specifically. So you can see by county of residence where the pockets are of heavy NAS diagnoses. However, it is affected in all of Pennsylvania, as you can see. So the Perinatal Quality Collaborative, these are networks of teams working to identify processes that need to be improved and quickly adopt best practices to achieve collective aims. So I'm very happy to report, you can see Pennsylvania there is green, which means Perinatal Quality Collaborative is available. This is brand, so they're new as of 2019. So our first meeting was in April of 2019, and it was many, many years in the making, and we are very, very excited and very proud of it. We were one of only about 5 or 6 states that did not have a Perinatal Quality Collaborative. So the opioid use epidemic has really put a focus on the need of standardization. And Perinatal Quality Collaboratives are not just for opioid use disorder. They focus on many, many maternal and neonatal issues, such as maternal hemorrhage, maternal morbidity and mortality, and other things with babies as far as infection, antibiotic use, and things like that. Anything that we can standard across maternal and neonatal stays. So we are just in our infancy here in Pennsylvania, but you can see on this graph that almost everybody now in the United States either have a Perinatal Quality Collaborative or have one in development. There are some that are very, very successful and have been going on for quite some time. California and Illinois, North Carolina specifically, have done a great job with their Perinatal Quality Collaboratives. Maryland's done a great job with their NAS, with their Perinatal Quality Collaborative. So it really helps break down those barriers amongst hospitals and allow us to treat these families as a unified approach through the state. So it's really quite incredible, and we will keep you updated on how things are going in Pennsylvania. So let me just pull this up. Okay, so the Pennsylvania Perinatal Quality Collaborative is a statewide perinatal quality collaborative, and so we have about 50 hospitals of the almost 100 birthing hospitals in Pennsylvania that are now included in the PAPQC, and it's growing every week. So We started initially by convening key players. We had to make sure that we had adequate funding. It started with the Pennsylvania Preemie Collaborative in partnership with the AAP and the March of Dimes. And then we were able to become partners with the Jewish Healthcare Foundation, which provided a lot of our financial backing. We are also now supported by the state, and the CDC is aware as well. So it's really quite exciting. We had to identify high need areas, and then our goal is to spread best practices and elevate the workforce roles and then advance policy. Our initial targets are for maternal mortality on the OB end, as well as opioid use disorder, and then on the neonatal end, it's neonatal abstinence syndrome. So this is where we're starting, and then we will branch out as these projects become more and more successful. So our goals overall is to have excellent attachment between the moms and the babies and to have happy and healthy families after the perinatal quality collaborative has become successful. And so the aims, as I have discussed, is to reduce maternal mortality and morbidity, to improve identification of and care for pregnant and postpartum women with opioid use disorders, and to improve identification of and care for opioid-exposed newborns. So this is one of the NAS driver diagrams. It is a very busy slide, but really the point of it is to say that there were a work group before the PAPQC got started. There was a work group that created this key driver diagram so that we could hand this to hospitals and say, this is what we think might help you in your hospital. Now you go back and decide which areas you need to work on, and sort of these are the interventions that may be helpful. So it's just a guide. It's something to really help people. Instead of just telling them to go back to their hospitals and figure it out, we want to be partners with the hospitals so that we can help them along this road. Really, the goal is to decrease the average length of stay in the hospital. We have small goals. Right now we have decreased it by just 1 day by December of 2019 and 2 days by September of 2020. Hopefully, by doing all of this, those numbers will be blown out of the water, but we did need to start somewhere. And then there's secondary aims and tertiary aims, which hospitals can choose what they are struggling with and what's important to them for their success. Some of the key drivers is to ensure safe discharge, standardized medical management of all NAS patients. It's really important for physicians and advanced practitioners to be giving the same message to the families, but also to be treating the baby the same way. The baby's dose of morphine, let's say, is supposed to be decreased because the scores, were below 8 for 48 hours. Then we need to do that instead of, say, Dr. Costello is working today and Dr. Smith is working tomorrow, and Dr. Smith tomorrow doesn't think that the baby should be decreased even though they reach all the milestones, because that will increase length of stay. It increases the length of time the baby's on the morphine, and certainly increases the length of time that the babies are separated from their families. And then you can see some of the interventions that are suggested, like using a cuddler program if the parents aren't available, increasing our lactation support to the families, creating and using NAS order sets, things like that. And there's a whole list that you guys can read. But it's just important to really support hospitals, because some hospitals are very used to doing quality improvement projects. Other hospitals, this is the first time that they've done anything in the neonatal realm, and so they really need more support. And so that is what this collaborative is all about. It's getting everybody on the same page, regardless of where their starting point is. The Vermont-Oxford Network has also partnered with the Pennsylvania Perinatal Quality Collaborative. So the Vermont-Oxford Network is an organization that has over 1,000 NICUs enter their quality data. So that's a database essentially, and you can follow all sorts of things like length of stay, mortality, pneumothorax, things like that, but we can also utilize them for potentially better practices. So they have created a neonatal abstinence syndrome toolkit that has 8 potentially better practices. And so if the hospital has decided to use this toolkit, then they can institute it throughout their hospital, and it standardizes how the nursing staff scores the babies when intervention is needed. And it is about, I want to say 50 webinars maybe, about 20 minutes each, about 18 hours of time that people will use in order to really become experts in this, so we can standardize the care across the medical community. So some of the signs and symptoms of NAS, it really can differ for every baby, and it certainly differs for what the baby is exposed to. But like I said, most happen the first 4 to 7 days, and then within the first 3 days is really where the significant symptoms come into play. Some can be right after birth, although not usually, and some can wait a few weeks after birth, but again, it's usually not that significant if it's a few weeks after birth, but it certainly does happen. And the symptoms can last from 1 week to 6 months after birth. The babies, it's very important to know when they are discharged from the hospital, they are going to still have symptoms of NAS. So because it can last for up to 6 months after birth, which is really important to teach the families how to handle these babies. These babies are going to be a little fussier. They are going to eat a little more frequently. They are going to be a little bit more difficult to console. So really having that support system in place, making sure they know who to call, making sure they know who their resources are, and how to keep this baby safe. The education is really, really imperative. So some of the signs and symptoms, which can be mild and it can be quite severe. They can be tremulous. They can have seizures if it goes on too long, which hopefully we don't get to that point. They can be hypertonic. They can have overactive reflexes, excessive crying, very high-pitched cries. They may have poor feeding. They might not be able to suck long enough because they're so uncomfortable. They might have vomiting. They might have extensive weight loss and might need to be on increased caloric density feedings. They might be premature, all of these things that we have discussed previously. And then when you think about a baby that is suffering from NAS, there is a whole system in place as to how to evaluate these babies. So now, as of 2018 or so, there is a new way. So most of us are used to the modified Finnegan scoring. So the Finnegan scoring system was developed in the 1970s, and over 90% of us still use the modified Finnegan scoring, and that is based on all of the symptoms that we just previously discussed. And if that baby, if that score adds up to be greater than 8 3 times in a row, that baby typically is transferred either to the NICU or the PEDS floor or wherever a hospital may be treating these babies, reevaluated, and then possibly start on medication. But now there's something called the Eat, Sleep, Console scoring system, which we will go over in just a minute, which is quite exciting and really has some great results already. NAS and breastfeeding is very important. So again, as long as there are not any contraindications, it's important to encourage breast milk and encourage breastfeeding, and certainly involve your lactation consultants because, again, they might be a little bit more difficult to latch, but breast milk is best for the babies. The medication that the moms are taking, a little bit of it will get through the breast milk, which will help with a natural weaning process. So it's really important to encourage breastfeeding. Rooming in, of course, we want to make sure that the moms are able to stay with the babies. So whatever we can do to support that. It's also important because the babies need to have that contact. They need to have skin to skin. They need to have that quiet, cool environment, and they need to be with their parents. And that certainly helps with the symptoms as well. If the parents are not able to stay, if you have a cuddler program in your hospital or if you want to develop a cuddler program, that is certainly a great substitute. It's never as best as a mom and a dad, but certainly it's somebody else if the parents are not available. And these volunteers come in and simply hold the babies for hours on end, and that certainly has helped as well. Those are some of the non-pharmacologic management methods that we have. And then, of course, the pharmacologic treatment options typically are morphine that we use in Pennsylvania. Rarely do we use methadone or buprenorphine. However, that is not a never event. It's just unusual. So there was a study called the Mother Study that was published in 2010. And this is really showing that moms that are treated with buprenorphine the baby's hospital stay is significantly lower. You can see about 18 days versus about 10 days for those moms that had buprenorphine versus methadone. The duration of neonatal abstinence syndrome treatment is significantly lower, from about 10 days to about 5 days, and the total dose of morphine is much, much lower, and you can see that in the graph as well, from about 10 milligrams to maybe about 2 milligrams per baby. So, and what we are all seeing in the environment is more and more moms are now being treated with buprenorphine that are pregnant versus methadone. So we're starting to see a decrease in our hospitals as far as our NAS admissions. But this is really new as of 2019 that we have seen this decrease. So this is just another study that shows the similar data that the percent of infants requiring treatment for NAS when the moms were treated with buprenorphine is about 20 to 47% of those babies, whereas methadone, it was 45 to 57% of those babies. So that was statistically significant. And the hospital stay for the babies are significantly different. In the buprenorphine group, it was a max of about 10.6 days. In the methadone group, it's closer to 3 weeks. So really a push to treat the moms with buprenorphine versus methadone during pregnancy. This is a slide that shows you the modified Finnegan scoring system. So again, it was developed back in the 70s, and most hospitals use this. And so the babies are scored every 3 hours, and they are scored on different signs that they are showing, whether it's a high-pitched cry, how many hours they are sleeping between feedings, what their tone is like, if they're tremulous, if they have rashes, if they have fevers, if they have excessive yawning and vomiting and watery stools and things like that. So every 3 hours, the nurse will score the baby, and then we follow the scores for the 5 days to see if they meet treatment criteria or not. And then once they do meet treatment criteria, they are typically transferred to the neonatal intensive care unit. However, more and more hospitals throughout not just Pennsylvania but the United States have other places in the hospital that might be a little bit more appropriate for these babies, because we do want moms and babies to stay together. Sometimes the peds floor is more appropriate because they have single patient rooms if your NICU does not have single patient rooms. We have some rehab hospitals that are appropriate for these babies. So it really just depends on the environment, that the hospital has. Certainly an open pod, brightly lit, very noisy NICU is not the best place for a baby that's experiencing NAS. So we're really trying to get better as to where these families can be. So this was a study that was published in January 2018 in Pediatrics, and this is really starting to change the way that we look at babies with NAS. So this was a novel approach to assessing infants with neonatal abstinence syndrome, and this is a study out of Yale. And so we see that, like I had mentioned, an estimated 95% of U.S. hospitals use the Finnegan Neonatal Abstinence Scoring System, or the modified Finnegan scoring system, which is quite similar, and it's based on 21 symptoms of opioid withdrawal. However, the researchers at Yale examined whether they can put in place a scoring system that showed more non-pharmacologic interventions for NAS in a modified approach called Eat, Sleep, Console, such as providing a low stimulation environment that we just spoke about, having mothers room in with their infants and feeding them frequently, which could help the infants go home sooner. So they did a study back in March 2014 to August of 2015 with 50 babies. And they scored these babies with both the Finnegan scoring system and Eat, Sleep, Console guidelines. And they found that of those babies, 30 of them, which was 60% of the infants, would have been started on morphine treatment if they followed the Finnegan scoring system. However, by using the Eat, Sleep, Console guidelines, only 6 patients, which was 12% of the 50 babies, were treated with morphine. So this is really a landmark study that is starting to change the way we approach these babies. So you can see this is the approach. It's very, very simple. It's very easy to follow, and it's really been quite successful. So can the baby eat greater than 1 ounce per feed or breastfeed well. So if it's a formula-fed baby, you want to see if they're eating enough. And if it's a breastfeed-fed baby, is that baby latching well? So if the answer is yes, then you move on to the next box. Can the infant sleep greater than 1 hour? So it's not 1 hour, 2 hours, 3 hours. It's greater than 1 hour. Yes. So then you go down to the next box. Can the infant be consoled within 10 minutes? Yes. And then you say that that baby is well managed, and we don't need to intervene. If any of those answers are no, you can see it goes into the next box, which really encourages even more non-pharmacologic interventions, such as feeding on demand, swaddling them, holding, having the parents present. If after all of that the babies still are not consoled, then the baby would be started on morphine and then weaned appropriately. So just a really novel approach, a common sense approach really to these babies, which is really helping with the morphine usage as well as the decrease in hospital length of stay. So these are some of the non-pharmacologic treatments of NES, so avoiding any excess stimulation, reduction in the environmental noise. So again, where are these babies being treated? Hopefully in a private room with their mothers. Making sure they're swaddling, frequent feeding, skin-to-skin contact, and encouraging breastfeeding when appropriate. This is just a breastfeeding endorsement policy statement that shows the safety of breastfeeding among opioid-dependent women and substance abuse treatment is supported by the AAP, the American College of OBGYN, and the Academy of Breastfeeding Medicine. Breastfeeding women should have no other contraindications for breastfeeding, so they should be negative for HIV, and they should abstain from using alcohol and illicit drugs, including marijuana. There's more and more reports coming about marijuana, but that's a different topic for a different time. So the pharmacologic treatment that you can see is there's morphine, methadone, and buprenorphine. However, most hospitals do use morphine to treat the babies, and you can see the half-life there, and then it's mixed in sterile water or ethanol, which is also one of the reasons why methadone and buprenorphine are not typically used in infants. The neonatal testing for drug exposure, oftentimes hospitals use urine, but then also meconium, hair, which is rarely used, and cord toxicology. Cord toxicology certainly tests for a lot more than meconium does, and it's certain that you can always get it because it is collected right at birth, whereas meconium sometimes either the baby's stooled in utero, or sometimes it's unable to be collected, or not enough is collected. So there's something that makes meconium a little trickier to get than the cord blood. And then when you look at the two comparisons between the meconium drug panels and umbilical cord tissue panels, you can see the comparison here as to what is tested for. So there are more things that are tested in umbilical cord, and the sensitivity is similar between meconium and umbilical cord. So some of the outpatient needs, we do need to make sure, like I said before, that families are familiar with shaken baby syndrome. We have to ensure all families have access to resources specific to their situation and have a plan of safe care, to refer all infants with NAS to early intervention. And then if an infant is experiencing withdrawal symptoms after hospital discharge and requires treatment, they need to be referred to a hospital that is familiar with NAS treatment. Not all hospitals treat babies with NAS. You have to make sure that the pharmacist is familiar with how to mix the morphine if that's what's being used. So it's important to know what your hospital is capable of so that baby isn't transferred to yet another hospital and again would upset the family. It's really a lot about expectations. If the baby is formula feeding, the baby should be on a more elemental formula, so a more sensitive formula to decrease GI symptoms, although again breastfeeding is encouraged. And consider having more frequent visits to monitor growth, monitor the family's stress, and to promote the education, make sure the families are getting what they need. We need to make sure it's a multidisciplinary, collaborative approach. So again, with MFM, with OB, with the neonatologists, and with the pediatricians, social work, lactation consultants, everybody needs to be involved so we can really wrap our arms around this family and really help them be as successful as they can be. We want to make sure that we are providing a non-judgmental and a compassionate approach to this family. Our words matter. So make sure that we're saying that babies with NAS are substance exposed. They are not addicted. It's really important because every word that we say, the families are really, really listening, and it's going to shut down any further conversation if we're not choosing our words wisely. We need to make sure they have a safe discharge home, a plan of safe care, and to have a network of local resources. So some of the resources we have are fantastic. However, our families aren't able to get there. So we need to know, do they have transportation? Can we help with transportation? Is there somebody that can come to the home? Things like that. So the plan of safe care, so on June 28, 2018, so just about a year ago, Governor Tom Wolf signed Act 54, which was consistent with CAPTA to require healthcare professionals, including those that are involved in the delivery or care of an affected infant or encountering an infant up to age 1 outside a hospital setting, to notify the Pennsylvania Department of Human Services so that a plan of safe care can be developed. So it's really important to know that we are all mandatory reporters, and we need to make sure that these babies are reported so that we can develop an effective plan of safe care. So an effective plan of safe care is an interdisciplinary across health and social service agencies. It's based on the results of a comprehensive multidisciplinary assessment of physical, social, emotional health, and safety needs of the infant and the parent or caregivers. It's completed when possible in the prenatal period, but certainly before the infant's discharge from the hospital. Easily accessible to relevant agencies so that everybody knows that there are safeguards in place so that this baby is discharged to a safe environment. The multidisciplinary teams may include representatives from public health, maternal and child health, home visitation programs if you have that in your area, substance use disorder prevention and treatment providers, mental health providers, public and private children and youth agencies, the court system, early intervention. So there's a lot of agencies that really should be involved to make sure that we have wraparound services for these babies and these families. And then upon determination that an infant has been affected by substances, whether prenatally at birth or in the infant's first year, the provider is required to notify Childline. Now, what's important to know is that this report does not have to be made specifically from the healthcare provider. So the pediatrician or another physician or the advanced practitioner don't have to be the only ones reporting. It can be somebody that is designated by the physician or the advanced practitioner. So it could be a social worker, it could be a registered nurse, it could be a patient care coordinator. Anybody that is designated by the team to be the reporter, they would be the ones to report to Childline. And the number is certainly in the slides, which is 1-800-932-0313. There's also a self-service portal from the Department of Health, which is www.compass.state.pa.us/CWIS, and again, those are in the slides, which will be available. And then most excitingly, in August of 2019, so just last month, a Neonatal Abstinence Syndrome report, 2018 report by the Bureau of Epidemiology was released. This is the first time that a report of this type has been published because in the past we really haven't had good data. So the Bureau of Epidemiology sent out a cloud-based survey to all the birthing hospitals so they could collect as much information about NAS and our babies as we possibly could. So in the slide, you'll see that there is a demographic characteristics and birth parameters of infants with NAS. So you can see about 91% of these babies were white, about 52% were male, about 87% had Medicaid insurance, about 19% had birth weight less than 2,500 grams. 91% did receive prenatal care, even though it was only one visit or more, but still, and about 47% of these babies received care in the NICU. The percent of NAS infants exhibiting specific symptoms, so of the symptoms that we had discussed, about 85% of them had tremors, 82% had hypertonia, about 64% had fever, and you can look at the slide to see all of the other symptoms that these babies had. About 50% of them had diarrhea or throwing up, so really important to see what they are eating and make sure they're on some sort of sensitive formula if they are formula feeding. The treatment type for infants with NAS, so 43% of them were treated with morphine, 30% of them were treated with non-pharmacologic measures, and 28% of them were not treated at all. Less than 5% of these babies were treated with either clonidine, phenobarbital, another drug, or methadone. So really, by far, morphine is the drug of choice once you get to the treatment of these NAS babies. The incidence as of the 2019 reports, the incident rates per 1,000 births by region of maternal residence, most of the NAS cases were in the northwest and the southwest region of Pennsylvania. However, there were a significant amount in the southeast, but there was about 670 NAS babies in the southwest, 251 in the northwest, 618 in the southeast, compared to only 90 in the north central region of Pennsylvania. Some of the resources that you can see, and these are on the slides, the Pennsylvanians can find public data related to infants born and identified as being affected by substance use or withdrawal symptoms resulting from prenatal drug exposure in the following places. There's the Annual Child Protective Services Report, the Pennsylvania Opioid Data Dashboard, the Department of Health, and the Pennsylvania Healthcare Cost Containment Council. So a lot of places that we can see some of the information that we may need. And then it's important to go through the different home visiting nurses that we have, family centers. OCDEL is really important. It's the Office of Child Development and Early Learning. So they have a lot of resources for our families as well. And the Early Learning Resource Centers is overseen by OCDEL, and they can provide a single point of contact for families, early learning service providers, and communities so they can gain access to the services that these children may need. I really wanted to thank you for allowing me to present this topic to all of you. I do apologize for the technical difficulties that I did not expect. And a quote from Maya Angelou that I think is really important, especially for this topic. I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. Thank you so much, and have a wonderful afternoon.
This concludes our webinar, and we want to thank Dr. Costello for her excellent presentation. And many thanks again to the Department of Health for the funding that made this webinar possible.